Professor Caroline is a researcher and lecturer at the Pacific University College of Optometry in Forest Grove, Oregon, and a fellow member and diplomat of the Cornea and Contact Lens section of the American Academy of Optometry. Patrick also serves as a council member of the International Society for Contact Lens Research, as well as a member of the International Association of Contact Lens Educators and the American Association of Optometric Educators. He served as a contributing editor at Contact Lens Spectrum for over 20 years and is on the editorial board of the BCLA's Contact Lens and Anterior Eye Journal. He's published over 300 papers on contact lens related topics and is one of the world's foremost educators in the field of contact lens research, design, and fitting. And now, without further delay, I'll turn the presentation over to Professor Caroline. Patrick, when you're ready.
Thanks, Mike, and welcome everyone. I'm excited to be with you this evening to share with you some new insights into a new lens design from Art Optical called Ampleye. But before we get into the specifics related to this design, I think it's important that we recognize the fact that today the contact lens industry is very much at a crossroads. That is, when a new patient enters into our office, we have to now make a decision. Is that individual a candidate for a corneal GP lens design or a scleral lens design? I'd like to share with you some insights we have related to this decision making. Today, we teach our students at Pacific University to evaluate the topographical map, but do it in a very different way from what has been historically done. That is, historically, we've always used the axial display map to describe the shape of the cornea, but it's important that we understand that the axial display map is simply a power map, a dioptric power map, and it tells us little or nothing about the shape of the cornea. The actual height or depressions within the cornea are best evaluated using the elevation display map that we see on the right. Here's a wonderful display of showing the axial and the elevation maps, and below those two maps we see the simulated fluorescein pattern and the actual fluorescein pattern. With the elevation display map, we can see that the cornea is highest in the periphery 360 degrees around, or better yet, about 180 degrees around. And we can see that down below at the 6 o'clock position, there is a fairly significant depression in this keratoconus patient's eye. That depression is where the fluorescein is actually going to pool. Where the lens is in closest apposition to the cornea is where the red, or the elevation, is actually displayed. And we can see that elevation begins at about 8 o'clock and ends at about 4 o'clock, exactly where our fluorescein thinning takes place. So it's easy to see from this demonstration that is really the elevation display map that does the best job of describing the physical shape of the anterior corneal surface. Let's take a look at this example. We have a patient with an axial display map illustrating a moderate keratoconus. Now what we do is we simply go in and measure the height of the cornea along the vertical meridian, and we see that up above the cornea is elevated 180 microns above a best fit sphere. Below, it's 110 microns below, illustrating the depression. And when we add those two numbers together, it totals 290 microns. That is, there is a 290 micron height differential between the superior and inferior cornea. Here we see an example where we have that extreme discrepancy between the height of the cornea. We see up above the cornea has 379 microns of elevation, below 276 microns, and when we add those up, it equals 655 microns. That is over a 0.5 millimeter discrepancy between the height of the cornea. Our data at Pacific University has shown that when that differential is in excess of 350 microns, this patient becomes less of a candidate for a corneal contact lens and becomes an excellent candidate for a scleral lens design. Here is our data on 87 patients, 127 contact lens fits. And we can see from our data that in the patients that had 350 microns or less of corneal elevation, we had an 88.2% chance of successfully fitting those patients with corneal GP lenses. It is when that elevation discrepancy is in excess of 350 microns that that patient may become an excellent candidate for the scleral lens design. As we know in clinical practice, there's a fair number of eyes that will fall into that category of having in excess of 350 microns. Many of them are keratoconic, ectasia corneas such as keratoglobus or bulging grafts, or patients with pellucid marginal degeneration. All of these become prime candidates for designs like the Ampleye. Now, what if you don't have a topographer? How do you tell if there's significant discrepancies in the height of the cornea? Believe it or not, that's fairly easy to determine. That is, you're looking at 6 different fluorescein patterns, and all 6 of these have in excess of 350 microns. You can see the tremendous areas of touch and then the tremendous areas of edge lift. Those are indicative of patients that have in excess of 350 microns. In other words, if the fluorescein pattern looks very, very poor, if it looks unstable, if the lens is rocking and pivoting on the cornea, that is probably a wonderful indication that this patient is going to be a good candidate for a scleral lens design. Now, scleral lens designs today basically fall into 2 fitting categories. Number 1 is the obvious, that is patients with irregular corneal astigmatism where those height differentials are significant. But of course the other category is that of ocular surface disease. When it comes to irregular astigmatism, the list goes on and on. Practically any cornea that has had any kind of trauma, injury, or surgery may be an excellent candidate for these lens designs. I had mentioned a little bit before about the pathologic ocular surface disease patient. This is probably one area in which these lenses are used with great frequency, and that is patients with chemical burns, pemphigoid, Stevens-Johnson syndrome, and a host of other ocular surface disease conditions. Now, one question we have to ask ourselves is why the rebirth of scleral lenses? We know that these lenses have been around since the early days of contact lenses in the 1880s. Why now this sudden rebirth? Well, the rebirth has been predicated on a number of features. Number one is that we now have high decay scleral lens materials. We have buttons that are in excess of 17 millimeters that can now be cut into these scleral lens designs. The two in which the Ampleye lens design is available is the Optimum Extra with a DK of 100 and the Optimum Extreme with a DK of 125. The other feature that we feel is responsible for this rebirth of these lenses has been a greater, better understanding of the actual scleral shape. You know, when I was in school, we were taught that the cornea had a curve to it, and the sclera adjacent to it had a curve to it. Believe it or not, our modern imaging has shown this type of drawing to be completely inaccurate. Today, we understand through OCT imaging that the anterior segment of the eye has a curve, but that curve only extends to a chord of approximately 10 millimeters. Beyond 10 millimeters, the cornea and sclera form an almost complete tangent or straight line. It is that tangent that has led to a series of new lens designs, new scleral lens designs that incorporate, instead of radii of curvature, actual tangents in the periphery. That's the backbone behind the Ampleye lens design. The Ampleye design has 3 or 4 different zones, a central vault zone designed to clear the central cornea by 250 to 400 microns, a peripheral corneal zone. This is an important area that is adjustable within this lens. We'll show you how important that zone is in just a few minutes. We believe that the third zone is instrumental in making a modern scleral lens perform well, and that is that the design clear the limbal area. The limbal area where the stem cells lie, we feel is an important area on which we try to avoid excessive pressure and bearing. Finally, the lens needs to land somewhere, and that is in the area of the scleral landing zone. So those become the 4 ingredients, components on the back of the Ampleye design. It's important to remember that all of these are adjustable, just like a hinge on a door. They can be raised up and they can be lowered. This is important because the area on which these are opposed to, the peripheral cornea and the sclera, are indeed a tangent, essentially a straight line. And this allows us the ability to use these tangents rather than radii of curvature in the periphery, which on a traditional lens design brings the edge of the lens closer and closer to the conjunctival tissue. These are the 4 zones as seen with fluorescein. As you can see here, the central vault zone does just that. It vaults the central cornea by that 250 to 400 microns. But adjacent to that, in the yellow, we see the peripheral corneal zone. It is important that this area clear as well. And the same can be said for the limbal lift zone. The limbal lift zone extends beyond the cornea and allows the lens to be elevated away from the limbal area. Finally, the lens lands on the bulbar conjunctiva in zone 4, what we call the scleral landing zone of the lens. The fitting of the ampullae design is really done by sagittal depth. Here we see a beautiful image of 5 different sagittal depth ampullae lenses, and you can see that the height of these lenses varies. One can measure the sagittal height at a chord of 15 millimeters if one happens to have an OCT that is capable of doing that, but there are other ways to fit these lenses. We like to fit by diagnosis, and that is we use the 9-lens Ampleye Diagnostic Set, and it's divided into 4 categories. First, we see the sag heights for the low and normal corneas. Then it's followed by the sagittal depth lenses designed for mild to moderate keratoconus. And then finally, the bulging grafts and advanced keratoconus and extreme ectasias such as keratoglobus. We have found that this 9-lens diagnostic set does indeed cover a wide range of corneal and scleral shapes that come into the practice. Now there is an expanded ampleye set. This was predicated on the fact that we found that in fitting many of our patients, they required a similar sag depth lens on both the right and left eyes. So the extended ampleye set incorporates additional lenses to allow one to place the same sagittal depth lens on both the right and left eyes. Now, another unique feature of the ampullae design is that it incorporates as a standard parameter of the lens a toric periphery. Studies at Pacific University have shown that most normal eyes have a significant amount of anterior toricity in the area of the sclera. So we've incorporated that amount into the back of the ampullae design, and we'll see some of the benefits of that feature later on in this program. Another wonderful feature of the ampullae diagnostic set is that it has on its cover this short fitting guide, which guides you in selecting that initial diagnostic lens. Once it is on the eye, it provides you insights into what to look for when making any parameter adjustments to the design. Let's do a diagnostic fitting. We see here a patient who has come into the practice with filamentary keratitis. Now, we anticipate that the underlying corneal shape is going to be fairly normal. This is a non-ectatic cornea, it's a non-surgical cornea, so the underlying corneal topography is anticipated to be normal. So for this normal shaped eye, we would go to our normal depth diagnostic lens, which is the 4000 sag height lens. That lens is cleaned and prepared and ready to insert onto the eye. The lens is placed on the DMV platform. The preservative-free saline is added, and the fluorescein dye is placed into the back of the lens. Now here, there are many different ways to apply the lens. I personally like to have the patient pull down their lower lid. I then reach around, pull back the upper lid, and just lift the lens directly onto the eye. With the patient holding their lower lid, it frees up one entire hand for me to have both hands working, applying the lens and holding the lid. Now, where are we at with these preservative-free saline solutions today? Well, in the United States, we basically have 3 or 4 choices. First, we have the inhalation solution, which is a hospital-grade saline solution that is available by RX. We also have 2 other preservative-free saline solutions, an aerosol saline called Simply Saline by Arm & Hammer, and the Pure Lens saline, which comes in a bottle similar to the Unisol bottle, which has now been discontinued from the marketplace. That is the Unisol. Now, there's another new saline that has come into the marketplace called LacriPure. This is a new product from Menicon. It is FDA approved for rinsing and applying the lenses to the eye. They too are in a 5 milliliter unit dose capsule, so it has some wonderful features to it which make it ideal for dispensing with the Scleral lenses. Now, for all of you who have applied a Scleral lens, you know by now the #1 complication is a simple air bubble underneath the lens. This happens when the lids are inadvertently touched or the patient should move their eye during the application process. It's important to remember that there is no way to expel these bubbles. The lens just simply needs to be removed, fresh solution applied to the back of the lens, and then the lens reapplied to the eye. Once this diagnostic lens is on the eye, we're going to evaluate it for that 250 to 400 microns of apical clearance. Now, if one has OCT imaging available, we know that the thickness of the Ampleye lens design is around 300 to 350 microns. And so knowing that information, we're able to determine the depth of the contact or the depth of the tear trapped beneath the contact lens. A very effective way to do it is with simple optic section. By viewing the anterior segment of the eye in optic section, we're able to see the actual thickness of the contact lens, the thickness of the tear film, and the thickness of the underlying cornea. With those 3 in focus, we can very much determine the thickness of that tear lens trapped beneath the scleral lens. Now, it's important that we fit the lens with this rather significant amount of apical clearance. And the reason for that is that these lenses have a tendency to rather dramatically settle into the bulbar conjunctiva. Now, this is unique for us in the contact lens industry. We never had lenses that settled to this kind of degree. And the reason for it is that bulbar conjunctiva is loaded with goblet cells. Those goblet cells, as seen here with the black arrows, are easily collapsed under the weight, pressure, and bearing of the scleral lens. So it's important that we overshoot our amount of apical clearance, i.e. the 250 to 400 microns, understanding that that lens is going to settle into the bulbar conjunctiva. Now, we have followed many patients over an 8-hour period to see when and how that settling takes place. And as you can see in this example, we see 130 microns of settling that takes place over an 8-hour period. Our studies indicate that on average, it's 127 microns of lens settling that takes place over an 8-hour period. Now, once we've established the volume of tear underneath the center of the lens, we're going to move out to see, does the lens clear the peripheral cornea? That is zone number 2, the peripheral cornea zone. Here we see a beautiful example of a lens with 380 microns of central apical clearance, but as you can see, we have fluorescein thinning taking place in the periphery, in that area of that peripheral corneal zone. It's important to remember that if you see that amount of dark fluorescein thinning immediately upon applying the contact lens, it's important we understand that this lens is only going to settle in further throughout the day, and that amount of peripheral corneal thinning or peripheral tear thinning is going to dramatically increase. It never gets better, it only gets worse. So when we see that amount of fluorescein thinning in the periphery, we know immediately that we need to make a lens adjustment. That lens adjustment is simple. It is just simply communicating to the consultants at Art Optical that that area, the peripheral corneal zone, needs to be heightened. And they will then change that peripheral zone 5 degrees up, just like a drawbridge, increasing the clearance in that peripheral zone. Here's a wonderful example of that same patient with that light peripheral bearing immediately upon lens application. And you can see here, by making that 5-degree change, when the lens was dispensed to the patient, we saw 360 degrees of adequate corneal limbal clearance. So it's important to understand that that area of the lens is 100% adjustable. It can be raised or it can be lowered depending on what you see with your pattern. Now, why is this important? It's important because if we have inadequate peripheral lift, we're going to have corneal staining. This is a unique kind of corneal staining. It's more like a roughened up epithelium. The epithelium gets raised and looks almost keratinized in the periphery. This is very indicative of a lens that has inadequate peripheral clearance. Now, zone number 3 is the limbal lift zone. This is the area beyond the cornea that we believe is important to create a clearance of the lens beyond the cornea and beyond the limbus. It is actually best seen with white light. Here we can see we've applied the contact lens to the eye. We see the fluorescein coming across the limbus onto the sclera, and this is exactly what we want to see with the white light. A little bit of that fluorescein bleeding across the peripheral cornea, across the limbus, and on to the sclera. This is our indication that there is adequate clearance in that limbal area. Now here's a wonderful example of a lens that has both inadequate limbal clearance and inadequate peripheral corneal clearance. By simply jettisoning up that peripheral or that limbal lift zone, we now have enough clearance that it picks up off of the peripheral cornea as well. So we must remember any change we make out in that limbal area, the limbal zone, is actually going to help to lift the contact lens up off of the peripheral cornea. Finally, that lens needs to land, and where it lands is on the bulbar conjunctiva. And here we use the conjunctival vessels as our guide to understanding how much pressure we're putting on that area of the eye. By following the delicate peripheral or the delicate conjunctival vessels, we can see in this example that those vessels are indeed open. We are not impinging anywhere in the periphery. Now, mild blanching is going to look very similar to this. We can see the blood vessels coming in, and then we have a zone of white where there's been a slight impingement taking place in the peripheral contact lens that needs to be corrected. We see that very nicely here in this image as well, where we see the conjunctival vessel coming in and a very slight area of impingement taking place. It's important to communicate this to the laboratory because this is a very simple adjustment for them to make in the design of the lens. It's very easy for them to create the additional clearance required for that particular patient's eye. One other important feature that's important to communicate is the fact that the nasal and temporal sclera have a somewhat different shape or topography. That is, our studies have shown that the nasal portion of the sclera is significantly higher than the temporal. Therefore, when any scleral lens design is applied to the eye, it's going to land first on the nasal side and then naturally move in the direction of least resistance, which means it's going to slightly decenter temporally. We see it very nicely in this image down below. The fluorescein pattern shows a slight thinning of fluorescein along the nasal side of the eye, as noted by this darkened area here, but that is simply due to that slight decentration of the contact lens. We have followed patients for many years with this kind of slight fluorescein thinning on one side, and it is yet to create any problems. So it's just the contact lens following its normal path of equilibrium, where the lens tries to find its opposing landing spot. So do be aware that when applying any scleral lens design to the eye, the lens may have a tendency to decenter slightly temporal. Once that lens has been placed onto the eye, we've evaluated all of the 4 zones of the contact lens, and over-refraction can be performed. Now, as in fitting any rigid contact lens, the bulk of the underlying astigmatism is going to be corrected by the tear lens beneath the contact lens. However, if some residual astigmatism is present, a spiral cylinder over-refraction can be performed, and the Ampleye design is available in a very effective anterior toric lens design. Let's take a look at a fitting example. We have a patient with moderate keratoconus in the left eye, and here we see the axial display map. And now we're going to place on that patient a lens with a depth of 4,400 microns. Remember, this is simply a starting point from which to design your contact lens. So that lens has been placed onto the eye, and immediately we can see that we have inadequate depth in the central portion of the lens. Now, the rest of the lens actually looks quite good. You can see the limbal clearance. You can see the lens clearing quite nicely in the peripheral cornea. We just need more depth to the contact lens. Now remember, we're going to have to raise this lens up to not only eliminate the fluorescein thinning in the center, but we also need about 300 microns of additional clearance to account for the settling effect of the lens. So here is that lens on the eye. You can see on the left we have inadequate clearance of the lens across the apex of the cornea, and what we really want to see is something exactly like this, where we do have adequate clearance. Now, to achieve that, we're going to go all the way up to the 5,000 micron lens. And that lens is placed on the eye, and sure enough, everything looks perfect. We now have adequate central clearance. We have our 300 microns of additional clearance beneath the lens. We have peripheral corneal clearance, and we have limbal clearance. Now let's take a look at this patient with Pellucid marginal degeneration. This is actually a patient with 18 diopters of against the rule toricity. We see some rather beautiful OCT imaging of the patient's horizontal cornea up on top and the vertical cornea on the right, illustrating the inferior thinning. Now on this particular patient, we're going to place on the 4,400 micron diagnostic lens, and this is what it looks like. What we see here is a very, very subtle thinning of fluorescein in this area right here, but we see an inadequate amount of clearance up on top. So here, since this is occurring in the area of the peripheral cornea, and it appears that we have excellent limbal clearance, we're going to communicate to the laboratory that we want that peripheral cornea zone lifted 5 degrees. This is the actual lens following that modification created by the laboratory. We now have increased the depth of the lens centrally, 125 microns, which has alleviated the thinning down here, and we've eliminated that area of fluorescein thinning up on top. We can see here that by simply placing one diagnostic lens on this patient's eye with 18 diopters of corneal toricity, we're able to communicate to the laboratory the necessary changes to make to create this perfect fitting lens. Now, this patient has been wearing this particular lens for well over a year now and is enjoying 20/25 corrected acuity with his scleral lens. Perhaps the most difficult patient for us to manage in clinical practice are patients who have had significant bulging of their graft. Here we see one such patient wearing an Ampleye lens design. You can see the sagittal depth of that bulging graft at a chord of 15 millimeters is 5,580. You could see, just for purposes of comparison, down below we have a normal eye, which is 3,735 microns. A huge difference in the height of those two eyes. Now, in this particular patient, we're going to place on our diagnostic lens that is 5,600 microns high. This is that diagnostic lens on the eye. And the only thing we're seeing here that is of any concern is that area of fluorescein thinning on the nasal side. You can see here excellent limbal clearance, excellent central clearance. We just communicate this to the laboratory, increase that peripheral clearance by 10 degrees or 250 microns of elevation in the area of the peripheral corneal zone, and now this is the final lens for the patient. Once again, we took what is an extremely difficult patient to manage with a bulging graft. We've placed one diagnostic lens on that eye. We've evaluated the fluorescein pattern, communicated it to the consultants at Optical, and we now have our final lens product. I had mentioned a little bit earlier that the Ampleye lens design is available in a toric haptic. This was all predicated on studies we performed at Pacific that showed that there was approximately 115 micron differential in the height of normal eyes. That is, from its lowest scleral spot to its highest. This was all accomplished through some wonderful technology. One, the precision ocular metrology SMAP 3D instrument that allows us to image the patient in 3 different areas of gaze. It stitches the 3 images together and provides us with a height map of the sclera. Where the lighter blues are peripherally is where the cornea, or I should say sclera, is the highest, and where the darker blue lies is where it is the lowest. And the same is true when we imaged our eyes with the Eaglet ESP eye surface profiler. It is another instrument that provides us excellent information related to where on the sclera is its greatest elevation and where is it depressed. Again, an elevation display map of specifically the sclera. When we compared the 2 instruments in a recent study, we found that both instruments showed about 115 micron differential between the flat and steep meridians. The orangish color is the right eye, and the green color, the left eye, and you can see here we have pretty good ideas of where the cornea or the sclera is its highest and where it is its lowest. With this information, we communicated that to the back side of the Ampleye design. The beauty of this is that we can now apply a scleral lens to the eye. The lens will then automatically turn to line itself up on those two principal scleral meridians. We use this to hold the contact lens into place and orient the contact lens so that the astigmatic correction can now be placed onto the front of the lens to correct any of the residual cylinder. There are laser etched marks in the periphery of the Ampleye design, and all we need to do is to communicate where those etched marks are, 360 degrees around the cornea. That gets communicated to the consultants as well as the over-refraction, and from that information they will be able to design the anterior toric Ampleye lens. Now let's take a look at an example of this in action. We have a patient here in which we can see a rather significant amount of with-the-rule toricity in the sclera. But the amazing thing is this happens to be a patient with a perfectly spherical cornea. Our studies again have shown very clearly that there is absolutely no correlation between the amount or location of the corneal stigmatism versus what we see in the sclera. They seem to be two very different forms of astigmatism. So remember that. Very often, patients with perfectly spherical corneas will have this toricity, and we're now able to take advantage of that toricity, utilize it to position the contact lens. Let's take a look at an Ampleye lens design on the patient. We have highlighted the markers so that you can see them, and now they are at the 180-degree meridian. Now I'm going to reach in and spin the contact lens around to the 90-degree meridian and watch as this lens moves into its final position. Again, this is a patient with a spherical cornea, but as we have found in our studies, almost all of these patients have a significant amount of scleral toricity that we can now take advantage of. This is how we orient the optics of the toric contact lenses in the Ampleye design. Well, ladies and gentlemen, that is it. That is a very quick review of this unique lens design. A lens design that is designed to have the appropriate amount of apical clearance, peripheral corneal clearance, limbo clearance, and landing on the sclera. We have taken advantage of all the latest imaging techniques to design the backside of this lens to take advantage of that unique toricity found in the human sclera. So remember what we had talked about earlier. When you're addressing a patient that you believe has significant height differentials in their corneas, high spots and low spots, that prohibit you from getting an adequate fit with your corneal contact lens design, those are the patients that become prime time candidates for the Ampleye lens design. With that, I want to thank you so much for your attention, and I look forward to addressing any questions we might have in the next few minutes.
Wonderful presentation, Patrick, and I'm back with everybody again. This is Mike Johnson, and we're going to take a look at some of the questions that have been asked here tonight. and we do have a few of them. So let's take a look. The first one that I see here, Patrick, how much changes in microns is really required or usually required if the scleral zone is mildly or moderately tight, or if you have some mild or moderate blanching?
Yes, if you have some moderate blanching, we do it in degrees, and we do it in 1 degree increments. You noticed in the discussion when we were talking about the peripheral zone, the limbal zone, we raised that up in 5 degree increments. But in the periphery, we just go by 1 step to 5 steps, with 1 step being just a subtle change in the periphery, and that is really very often all that's required. If I see any impingement of those conjunctival vessels during the diagnostic fitting, I will request that we raise that area up just 1 degree. And in the periphery, that 1 degree change is indeed clinically significant.
Okay, and I know the art optical consultants will consider that 1 degree to be 25 microns. So,
okay.
So that 25 microns is probably going to be sufficient then. Beautiful. Okay, here's another question. This is an attendee that actually has steeper K, so I'm just going to kind of rephrase this slightly, but K range is 47 diopters, and they tried on the trial lens using the normal, which was probably the 4000 sag, and had central touch. So, you know, would somebody in the 47 diopter range require a steeper sag right away to begin with, or would we still start with the 4000 if it's a normal cornea?
I would still start off with the 4000, but you know, I'd take into account the central K rating and the size of the cornea. We do know that larger corneas are going to have that greater sagittal depth, and therefore if you have that combination of the steep central K rating and a larger than normal visible iris diameter, that's the 2 ingredients that will tell you that you really need to move to a greater sagittal depth lens. So a good observation, whoever made it, but again, you know, it's that combination of elements, the steep central K readings and the larger than normal visible iris diameter.
Okay, and here's another question. Okay, get here because they're flying in, so I want to make sure that I got the right questions here. Does Ampleye offer localized vaulting for pingueclia or bleb or pterygium?
No.
And I guess I'll answer that one, Patrick, because that would be quadrant control, and we will be that will be coming online probably within the next you know, a couple of weeks, anyways, or maybe a month at the most. With that, we are just validating that quadrant control process where we can lift that specific quadrant. We know exactly where that is, and we will be able to raise or lower each quadrant individually. So that will be a feature that will be coming very soon, and we will make an announcement when that's available. Okay, here's one about topographers. You know, there's many topographers on the market. Is there one out there that you recommend as a better unit for fitting these types of contacts?
Well, all I can say is that we've evaluated quite a few at the university, and the one we settled upon is the one you're looking at right now, and that of course is the Medmont corneal topographer. It's been quite a workhorse for us over the past few years, but you know, there are others on the market, and it's worth taking a look at all of them before you purchase it, making sure it has all of the features that you're looking for: the axial display, the elevation displays, the tangential displays, and provides you with the as accurate readings as you can get.
Okay, and here's another question. Do you have to compensate the base curve for central clearance if you change the periphery of the lens?
No, you don't. And that is that the power of the tear lens trapped beneath the scleral lens is going to be determined by the curvature of the cornea and by the curvature on the back of the lens. Now, if neither of those change, the thickness of the tear lens increases, but its shape doesn't. Therefore, it is not necessary to make any power adjustments.
Okay, and here's another question. So can the scleral toricity be adjusted from that 150 microns that's in there?
Oh yes, I was remiss by not mentioning that. We've had patients with up to 500 microns difference between their flat and steep scleral meridians, and we've had to dramatically increase the amount of toricity to prevent air bubbles from getting in the periphery and so on. So that is a 100% adjustable feature on the Ampleye design.
Yep, and I know that we can adjust that up to 375 microns of toricity. So we do have a pretty good degree of range with that.
Mm-hmm.
So here's another question, and I know there's a lot of questions here, and we're going to have to really sum this up fairly quickly, but I'm going to run one or two more questions by you, Patrick. Okay, here's one that one of my patients has, hold on, another one just came out. One of my patients has had glaucoma surgery recently, or filtration surgery. Can this be used on these patients?
It can be, but it's going to have to be modified. What we'll frequently do is go to a smaller diameter lens design, to a 14.5 millimeter lens design. Mike, you can fill us in on what's available in the smaller lens designs.
Well, right now we're able to get down to 16 millimeters. I know that in the near future we'll probably be able to get down to 15 millimeters with this lens. I'm not sure we're going to be able to get smaller than 15, but then we will also have the quadrant control if we need a little bit more lift for that area as well.
Absolutely, yes, exactly.
Here's a simple question. You know, as far as comfort goes, should topical anesthetic be used during fitting?
It's rare that we have to do that. It's only on an extremely apprehensive patient that we need to use a topical anesthetic. So I can probably count on one hand the number of times we've had to do that. I think every scleral lens fitter loves to do it without anesthetic, just so patients can actually enjoy the feel of having a lens on their eye without feeling it on their eye. I think that's the thing that has been most surprising about scleral lenses, is that initial and long-term comfort of the lenses.
Great. I'm going to go one more question here, and then we'll summarize real quickly. What's the thickness of the Ampleye trial lenses?
The thickness is 300 microns.
Yeah, 0.30. That's correct. Okay, wonderful. Now, I know there's more questions, everyone, and we will make sure these questions are answered individually, so you will get an answer back to us from email. We do have everybody's email address for that. Before we close this evening, I do want to mention that on Art Optical's website, on our Ampleye page, we happen to have a virtual trial set that's on that. It's a very nice thing that we've got going here, where you actually have 5 different cases, and you can pick each case. It will take you to the diagnostic set. It will allow you to pick several or 2 or 3 different trial lenses or sags out of the trial set, place them on the patient, let you see the evaluation of that lens on the patient, and then go to a different diagnostic lens. It will show you the overall fluorescein pattern. It'll give you the parallel pipe bit cross-section of showing the clearance of the lens, and it also shows the OCT image with it. So very nice, versatile, interactive thing that we've got going with this virtual trial set. And with that, we're going to have to say goodbye for the evening. Patrick, thank you so much. You've done a wonderful job, and we do appreciate everybody showing up for this presentation tonight, and I hope that you will give Ampleye a try. And again, if you have any other questions, please do not hesitate to call our consultation department. They would love to talk to you. So with that, I will say farewell, and again, thank you so much, Patrick.